So hi everyone. Thank you so much for signing up for our seminar today with Vicki Ruskin. So Vicki has worked extensively in rehabilitation, both as a clinician and as a manager, and has extensive experience working across all compensable schemes, and she provides expert medical legal assessments. So Vicki's area of clinical expertise is OT driver assessments driving, cancer rehabilitation services, and complex case management. I would ask for you guys to mute yourself during the presentation. And if you have any questions, please put it in the chat box, or you can leave it for the Q&A session at the end. Thank you. Over to you, Vicki.
Thank you, Sophia. Thank you for everyone giving up their time today to be with us to talk about cancer-related fatigue, something that I'm very passionate about. And I hope you find this session very useful. I'm really happy to have some questions at the end. Just in addition to what Sophia mentioned, I've worked for over 34 years as a clinical OT, and I've worked extensively within life insurance. I actually had a provider with the main focus of supporting people with cancer over the past 10 years. We actually did a lot of work with insurers in helping highlight the needs of people with cancer in the scheme, and successfully I partnered with Westpac to create the CAP. That was actually an award-winning innovation where we were screening all members at time of lodgement for their needs, and also touching base with them throughout the claim and the type of support that they would need. That work really fueled my passion for cancer supportive care. And as most allied health professionals, we do not have cancer as an undergraduate subject. So I actually completed my Master of Cancer Science, which was a degree with the University of Melbourne and the DCCC. I completed that last year, and my research capstone on fatigue, I was fortunate enough to present that to the multinational Association of Supportive Care in Cancer. They actually have the journal Supportive Care in Cancer at an international conference in Japan last year. So enough about me. So the objectives today, I thought we'd just touch briefly on the biology of cancer, the main treatments of cancer, the side effects of treatment, cancer-related fatigue, what is it, the management of the fatigue, and how this actually impacts people in their life and their work. So what is cancer? Briefly, it is a collection of cells growing and potentially spreading within the body. We call it uncontrolled cell proliferation. And apoptosis is actually a natural process of cell death. It's a highly regulated chemical process whereby cells have extensive cell damage and spontaneously undergo apoptosis. It's important to understand that because the aim of chemotherapy and radiotherapy is actually to damage the cells so they die. Current evidence does support that a lot of cancers can be related to the damage to genetic blueprint of the cells, and many cancers can be linked to mutations in those genes. And this actually explains why cancer increases with age and why some familial cancers are inherited. Tumor viruses also cause cancer by either altering the expression of the oncogene or the inactivation of tumor suppressor genes. That's a very brief explanation of the biology. I thought it'd be helpful just to touch on the types of cancer, because I'm sure we've all come across these and sometimes it can get very confusing. But simply, a carcinoma is a cancer that begins in the skin or in the tissues that line or cover organs, for example, melanoma. A sarcoma is a cancer that begins in bone, fat, muscle, blood pressure, blood vessel, or other supportive or connective tissue, for example, an osteosarcoma. Leukemia begins in the tissues that make the blood cells, such as bone marrow. You might get acute myeloid leukemia, for example. Lymphoma and myeloma are cancers that start in cells of the immune system, for example, in Hodgkin's lymphoma and multiple myeloma. And central nervous system cancer begin in the brain or the spinal cord, for example, glioma. So the main treatments, these are by no means inclusive, but I think it's important to touch on the treatments because in unravelling and unpacking cancer-related fatigue, one of the first things we need to understand is often the diagnosis, the staging of the disease, but also the treatments that someone may have had and the effect of those treatments. So surgery can be used for diagnosis and staging. It might help to diagnose the type of tumour and to actually understand whether it's actually spread or changed. It can be used as a first line or primary treatment. It could be the removal of a tumour and no further treatment is required. Or it could be part of a combination of treatments, or it could be used in palliation, which is when it may be causing pain or obstructing other organs. I was just going to give some examples. I love talking examples because I think it makes it real. I did work with a fellow with tongue cancer, Mr. J. He was actually an emergency physician. So he was on his feet for 12, 18 hours a day, and the physicians often just eat on the run. But when you've got removal of half of your tongue, the way that you actually eat and you chew and you swallow is very different. So he actually needed to take longer in order to move the food around his mouth and chew. It would often take him up to an hour, and he would then have to use a water pick to actually remove food products from his mouth. This was incredibly distressing for him. It was also a very big barrier socially, but also with work. He also needed radiotherapy around the neck, which caused ongoing lymphedema, and this was, a year, 18 months post-treatment. The removal of organs can cause ongoing issue and often sometimes even a permanent disability. Another lady I thought that was worth touching base on was I worked with a young woman who had removal of a brain tumour. This was at a premier Sydney hospital, and she had returned to work on partial hours, but the employer was actually not aware. They knew that she had a brain tumour, but they weren't aware they just assumed the surgery had removed it all. And they weren't really aware that by removing brain tissue, this woman actually had permanent loss of brain tumour in a particular part of her brain that was actually leading to a change in behaviour and a change in cognition. They had assumed, without understanding and without having the proper input, that there was issues with performance and had instead gone down a performance management route. A neuropsych assessment, interestingly, and we'll talk a little bit about that later on, was unable to quantify the impact of the cognitive changes. And rather, as an OT, what I did was actually unpack the tasks, the requirement of the tasks. I tested her function, and we were able to come up with some strategies to remediate some of that loss of cognition that she had because of the surgery. So surgery is by no means a simple process. The other main treatment is chemotherapy. Now, chemotherapy mainly works by killing cells that are rapidly dividing, such as cancer cells. But those cells are also in our nails, in the lining of our gut, and in our hair, which is why often they're the things that we lose first when we're undergoing such a treatment. You'll see terms like neoadjuvant and adjuvant. Neoadjuvant means that it might be prior to the main treatment. So, for example, in some cancers, chemotherapy will be used to try and reduce the size of a tumour so that it can actually then be surgically removed. And then more often than not, people may then also continue to adjuvant chemotherapy, which is ongoing treatment and possibly some additional treatments. Now, the way that chemotherapy is given, it can be given orally, or it can be given via portacat, or it can be given via a IV infusion. Again, there are some risks with some of, particularly with the portacat that's inserted under a simple surgical procedure, and they are often left in situ well after the chemotherapy has been finalised, and when the surgeons and the oncologists actually feel that the person may not need, further treatment. They can often also be uncomfortable for people. They can impede things like dressing, wearing of seatbelts, and often upper limb function. And I think the other thing that I wanted to make is the point with chemotherapy. When we read about chemotherapy, often in a lot of cancer literature, and it is certainly most definitely true, there's been a lot of work in how we can actually manage things like vomiting and loss of hair, and to manage GIT dysfunction with the chemotherapy, and often anti-nausea agents are added to the infusions. However, the things like fatigue and cognitive impairment and neuropathy are still very hard to manage. So those acute symptoms of chemotherapy we're getting better at managing, but the longer term symptoms of chemotherapy still remain. Radiotherapy, I think one of the interesting things, this is a very accurate way of targeting tumours and cancer cells, because the radiation oncologists are almost like physicists. So they look at a person's body matter, the density of their weight, their height, the density of the tumour, and the ionising radiation is calibrated so that it can be most effective while also trying to miss other major organs. So one of the issues, and it still does often arise for breast cancer, is actually not damaging the lungs and the heart through radiation. So the main aim is to not cause that damage. Cells that aren't cancer cells that are damaged by the ionising radiation will generate. However, there can be other issues that arise out of that. The other point to make is that the effects of radiotherapy are cumulative, which means when someone finishes radiation, it doesn't mean that those side effects will become apparent straight away, because the benefit of the ionising radiation is that it continues to promulgate and propagate until that energy of the radiation is burnt out. So when someone is getting a dose of radiation, the radiation oncologists are actually looking at the cumulative dosages over a period of time. So that's why sometimes people will often feel the effects of radiation later and often more long-term. As I mentioned before, I've worked with a fellow with head and neck radiation. That can be difficult because you can get things like lymphedema. I'm just getting my other notes up here. Lymphedema for head radiation, seizures. I actually worked with a very nice man for a number of years who had brain cancer, and the effects of the radiation left him with seizures. They were difficult to control. They meant he couldn't drive. They meant that he was a bit of a risk on public transport, and the workplace were also very concerned about managing those seizures at work. So that's radiation. As I said, this isn't conclusive, but these are some of probably the main treatments that you'll hear about. The immunotherapy is a treatment that harnesses the person's immune system to fight cancer, helping them to destroy cancer cells. There can be a range of immunotherapy sort of treatments which you may have heard about. T-cell transfer is being used with a lot of lymphoma. It is very expensive. Not all of it's readily available, but as you know, we've got we're trialling immunotherapy even for cancers that we didn't even think was possible, such as the fellow with the Australian of the Year. We're using immunotherapy for brain cancer. In working with people that go through immunotherapy treatment as an OT, the effects of immunotherapy are individualised, but because we're harnessing the immune system, we often get an increase in pro-inflammatory markers, which can cause things like reactive arthritis. I did work with a fellow that had melanoma, but his response to immunotherapy was so severe that he was initially unable to even transfer out of a chair. He had severe joint pain, and the way to manage that was through steroids. However, the steroids prohibited his ability to sleep or rest. So we're in a bit of a cycle of either putting up with pain and loss of function, or some pain, some loss of function, in addition to inability to rest, and then the mental health load that comes with trying to manage such conditions. I have worked with people who then go and see rheumatologists that go back into the health system. So they may have a medical oncology team, but they'll also be seeking advice from rheumatologists due to ongoing sort of arthritic type symptoms as a result of the treatment. Hormone therapy is otherwise known as endocrine therapy, and this is a therapy that uses substances to stimulate or suppress specific hormones to grow. So it's used for two reasons, either to stop or slow a cancer's growth or to ease cancer symptoms. So the people that tend to use endocrine therapy, usually after a combination type treatment has been completed, are those with breast, prostate and thyroid cancers. Again, I would say that this is very impactful for a person, because often the treatments, particularly as you would know with those cancers, breast, prostate and thyroid, the endocrine therapy is actually spanning years. You know, for breast, it's minimum 5 to 10 years. The people are living again with the side effects, which can include cognition, fatigue, pain. One young woman I worked with who had hormone positive breast cancer had quite a severe response to the endocrine therapy, and so much so that she was unable to open her fingers in the morning. It meant she couldn't type, she couldn't grip things, she couldn't hold things, and she had to start her day with almost like gentle exercises to get some function back into her hands. She was also put into an induced early state menopause and experienced quite severe menopause symptoms because it was chemically induced almost immediately. The loss of sleep, loss of cognition, emotional changes, joint pain were quite severe. As an OT, what we look at is where we can actually assist with function. So I worked with her mainly, firstly, it was around her mental health, her depression, her loss of her fertility, so there was grief. It was around trying to accept what she needed. She needed a lot of reassurance that it was worth the side effects to remain on the endocrine therapy. So, she was recommended to stay on it for 10 years. She was under 40 when she was diagnosed. And to then help her with either assistive equipment or pacing or breaking down the tasks that she could do at the time where her function was the best, because it was this was a person that was very high functioning at time of diagnosis, and it was actually not so much the cancer, it was the treatment that meant that she lost all this function. Just touching on the long-term side effects of cancer, there is a lot of side effects, this is not inclusive, but just running through them quickly. And I guess this is where, as a therapist, we get involved in helping people to function and manage these sort of limitations post-treatment. The surgery, obviously, it could be an amputation of a limb, it could be removal of an organ, it could be a removal of the prostate and then the subsequent loss of sexual function. It could be the loss of, I worked with a man that had stomach cancer and they made bladder cancer. He lost his bladder and he had an artificial bladder as remediation. That actually left him with sexual difficulties but permanent incontinence. And he was a young man, 52. Heart problems, hypertension, lung problems, commonly, particularly when you're looking at radiation around the chest. Endocrine system problems, as I mentioned before, early menopause, infertility, bone and joint problems. Osteopenia is a loss of calcium due to chemotherapy, which leads to more fractures. Reactive arthritis, I've seen as a result of immunotherapy. That can be very debilitating, means it's pain and loss of function, range of movement. Brain, spinal cord and nerve problems and pain. Vision problems. I once worked with a lady that had detached retina from the chemotherapy. Digestion problems are very common. If we would go back to John, the doctor that worked in emergency with the tongue cancer, his digestive system was very disrupted, but he was also unable to, because it took him so long to chew, he actually didn't have enough time to actually get the calories in that he needed to meet his BMR. So he had lots of difficulty trying to actually find a diet that meant that he could get the appropriate nutritional needs. Emotional difficulties, FACR, I've put some language in there because you might see this. This is an accepted mental health diagnosis. It's fear of cancer reoccurring. Where we might see people locked in that is it can be very self-limiting, or it could be that they are exploring and upending their lifestyle and upending nearly every aspect of their life because they've got a fear or a belief that how they were living was actually attributable to their cancer diagnosis. It's a very real condition, and as I said, it can become a barrier for people in actually moving past that treatment. Secondary cancers are a risk of most cancer treatments. Fatigue, the correct definition is CRF, which is cancer-related fatigue, and we'll go through the definition in a moment. Pain, the correct definition for neuropathy is chemotherapy-induced peripheral neuropathy. What we think is attributable to CIPN is because the nerve endings in things like toes and fingers are so fine, the chemotherapy agents destroy those cells quite easily, and it actually takes some time for that function to return. That can include pain, numbness, sensitivity, difficulty with tasks like doing up buttons, shoelaces. I worked with a lady, she was actually a legal lady who had ovarian cancer and was unable to prepare documents because typing on the keyboard was just so challenging and so painful, extremely painful for her. And she actually came up with the perfect solution. She put some acrylic nails on, so she actually didn't have to use her fingertips, which were just so sensitive when she was typing. The correct term for cognition is CRCI. And I might just talk about that for a moment. CRCI is cancer-related cognitive impairment. Like CRF, we're actually not entirely sure of the pathophysiology of the changes in cognition, but we can assume that for some chemotherapy agents, for example, they pass through the blood-brain barrier and can cause some damage. We know that treatments cause pro-inflammatory markers to circulate around the body, like cytokines, which we are attributing to a possible factor in fatigue and cognition. And with cognition, in my experience, the neuropsych assessment does not adequately identify what the issues are and what the remediation strategy should be. Because often a person's underlying executive function and their IQ remains the same. It's more the parts of cognition of retrieval of some types of memory, working memory. It's things like word finding and concentration and attention. So how I assess that, there are a range of validated assessments, mainly through the FACIT, F-A-C-I-T org, that we can use, that just tries to pull apart what could be contributing to some of the cognition and how impaired that cognition is. And again, as an OT, it's about looking at the task, trying to remediate the task by either providing adaptive strategies or equipment, or matching when they've got the energy for higher level executive tasks, matching that to the pattern in their day, whether it be work or just day-to-day work. I'll give you an example. I had, again, a young doctor undergoing chemotherapy for metastatic breast cancer, and her problem was she just forgot how to put down and put up the garage door. So she actually caused extensive damage to a car because she kept on just unable to actually process which button to press and which button not to press. So it's things like that. It's things like people will prepare a list, but then get to the shops and actually forget they've got a list. And all of these long-term side effects, we are not preparing people for or talking about. We give people handouts where we will mention this. But in my experience, like I've worked with hundreds of people. In the CAP, for example, we just had 69, over an 18-month period of people that we worked with. Repeatedly people are saying that they are surprised at the types of side effects they have and how impactful those side effects are on function. So, as I said, as an OT, we are very much looking at pulling it apart, looking where we can build function, or if function, whether it be physical function or cognitive function or emotional function, then looking at ways that we can either support or maintain that function. And we do that through assistive equipment, education. I also, probably what I didn't mention, I'm also a qualified integrative medicine practitioner coach, as well as a wellness coach. And I approach my coaching with people with cancer because it is a complex myriad of symptoms and different treatments, and then people's lifestyles and their pre-medical history are just so different. Is helping people actually to understand the tools that they can actually use that actually help their well-being. But because by even having a sense of well-being and a control often helps people manage these things a lot better. It is a little bit depressing. I apologise for that. I just thought I would call out, because again, it's pretty surprising for some people what the stats are. And this data has come from the Australian Institute of Health and Welfare, as well as Cancer Australia. They produce reports every few years, and there's actually some tools in those websites that you can actually manipulate the data and look at the data more in depth. But in summary, we're looking at the number of new cancer diagnoses may pass 200,000 by 2033. In 2022, there were 162,000 new cases diagnosed, and in most developed countries that collect cancer data, this data is similar, and cancer remains in the top 3 causes of death. Males are more likely to be diagnosed than women. And what I would like to say just about and it's not just for Australia, but internationally, the impact of COVID on cancer screening and cancer diagnosis. We suspect that we're going to actually see in the next few years later stage diagnoses, because, for example, in the first lockdown, Australia actually closed the breast screen program, the National Breast Screen Program. And that backlog of women, we're still trying to catch up. So our 3 national screening programs, we have the National Bowel Screening Program, the Breast Screening Program, and the Cervical Cancer Screening Program. So we are anticipating that we will be seeing people at a latter stage of the disease, and we're anticipating that that will create a greater burden on cancer treatment and cancer ongoing care. Cancer in the working age population, 40% of people diagnosed are of working age, 20 to 64. And whilst most of them are 65 or older, I think the other point to call out is that their main carer may actually be a younger person of working age. And there are currently 1 million people living in Australia who've had a cancer diagnosis, many of whom have those side effects that we went through in the earlier slides. So therefore, cancer for many people has become more of a chronic disease. I did want to actually talk about Sarah as another example of someone. So she was a COO of a large company and had a diagnosis of breast cancer. I was fortunate enough to start working with her in treatment, and I was beginning to talk to her about how she may feel after treatment, but she really had the personality of you just push through. You keep trying and you keep pushing through, and my will overcome. What we know is that that just doesn't work. And in setting up people for recovery, a lot of the work that I do is actually helping people accept that it is a process, that no amount of motivation and self-will can often overcome these things, that their body has it's been ravaged by a range of treatments, and that it takes actually some time and work to actually build that capacity back up. She went back to work 3 days a week, 4 hours a day, however, returned to her same role. So, of course, she was unable to do her role in the 4 hours, so she was working longer. And she was returning home by 6 o'clock, so fatigued that she'd be in bed by 7. And then she was just working to try and get up again and go back to work. Huge impact on her family. She had 2 young boys. And in 12 months that we were working, she was unable to get past those 3 days, 4 hours a week. She was becoming increasingly frustrated, increasingly depressed. She actually ended up with a clinical diagnosis of severe depression, and she actually left her employment and remains unemployed. So it is an issue. It's not an understood issue. I also do a lot of work with employers. I've worked, for example, with Johnson & Johnson with their national and international team, and actually doing similar presentations so they understand when people are coming back to work, how is the best way that they can actually support them so that the outcome is actually positive. These stats, whilst they're not Australian, we actually don't collect this level of statistic, but this is from the Macmillan organisation in the UK, which is a premier cancer charity. We're talking about huge numbers of people that are living with fatigue, living with sexual difficulties, which then is impactful on relationships and self-efficacy, self-worth. People living with fatigue that still can't function at the level that they were once functioning, whether that be at work or at home. 240,000 with mental health problems, whether that's fear of cancer reoccurrence or anxiety and depression. I've even seen people with a clinical diagnosis of PTSD because the shock. I had one lady, again, a very successful executive, I actually used to go with her and meet her at the hospital to have her chemotherapy infusions, because her terror at, she had actually had a very bad experience with one infusion, which required a spinal tap and excruciating pain, and it was a complete trauma response every time she turned up to hospital. People living with pain, that can be neuropathy, but that can be the joint pain that we've talked about before, or it can be pain from removal of an organ. It can be pain, a variety of pain. Living with incontinence, the fellow that I mentioned before, he was actually a film producer, and he used to do a lot of work overseas, you know, doing, the word escapes me, programs. And his incontinence just meant that he couldn't do that anymore. It was very embarrassing. I assisted him as an OT to actually get into the National Incontinence Scheme, and we've also got a New South Wales Incontinence Scheme. And these are problems, you know, respectfully, that do not get picked up when someone is in a primary health system, which is what cancer treatment is. Cancer treatment is about primarily saving life and diagnosing, staging, and providing treatment. But these issues are rarely picked up, they're rarely discussed, because we don't have the resources, or I would go so far to say enough allied health professionals with the skill and the training to actually manage these complex issues. The fellow with the incontinence, many didn't share a bed with his wife. The problems go on and on. I guess as an OT, I love my profession. I'm extremely privileged because I get to delve into people's lives and help support them to navigate some of these issues. Sexual difficulties is a huge area that people have no resource in. I once worked with a young woman who had radiotherapy for ovarian cancer. The result of the radiotherapy meant that her vagina was actually adhesed. The only thought the medical oncologist could was send her to a gynecologist who could meet an examiner, and she was just told, maybe she's got bigger problems, don't worry about it. You know, I've got lots of stories like this. People living with ongoing GIT problems. If you've had stomach cancer, the fellow that I mentioned with stomach cancer, his stomach was resectioned up to his upper chest. So you're talking about eating frequent, smaller meals, managing reflux, pain of reflux, the embarrassment of reflux, the vomiting, the nausea, which will be very long term. The same with lymphedema. So, and interestingly, I think I wanted to also, and this is not the point, is to point out, you know, to point fingers, but to point out that there are gaps in care. There is a gap in knowledge, and there is a gap in resourcing around these type of issues. I recently met a woman who's in palliative care. She was receiving her palliative care through a private hospital, but they actually only offered her pain management. She perceived that they just wanted her to die because that's all they could talk about. It was not my experience of working in palliative care, and actually the definition of palliative care is that it is a service for people with life-limiting illnesses and diseases. It can be, but is not always about end-of-life care. So palliative care should be looking at people's comfort, how they actually sit as they lose weight, how they travel to the hospital, just to check in, how the family coping. And unfortunately, this wasn't the experience with this lady. It's creating a greater burden on, you know, back to the GP who may not know, or back to family who are scrambling, trying to actually find solutions to problems that they just can't manage. So, and I'm sorry if this is upsetting or triggering for anybody. I'm also very happy to talk offline or make contact with anyone if this has brought up any issues for anybody. as we work through the slide. The cancer-related fatigue, my particular passion. We have an organisation called the National Comprehensive Cancer Network in America that was set up. It's also got the National Cancer Institute. I think it was set up by Hoover many, many years ago, thinking that they would come to a cure of cancer very quickly. And here we are in the 2000s, still no closer. But the NCCN got together, and this is in the literature and in research and in best practice, this is the definition that should be referenced. They got together because we needed to make it very clear that cancer-related fatigue is not similar to other chronic fatigue or post-viral fatigue or other fatigue conditions. And the definition, which sort of is similar like to a DSM-5 definition, is that it is a distressing, persistent, subjective sense of physical, emotional, and or cognitive tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity and interferes with usual functioning. So people can say to me, Vicki, I was just sitting on the lounge watching TV and I became so tired I could not speak. That's the type of fatigue we're talking about. So my paper that I presented in Japan was about trying to see if there was an objective measure of cancer-related fatigue. And my paper was about heart rate variability as an objective measure of cancer-related fatigue because, you know, health professionals trying to do their best. You know, I know in life insurance, we are using HRV as measures for fatigue programs. I completed a comprehensive literature review and analysis of that review, and the conclusion was no. The current literature shows that the possible causes of cancer-related fatigue we do not understand. So the pathophysiology is yet to be determined. We suspect that it could be a range of possible things involving several physiological and biochemical systems. It's related to the type of tumour, the type of treatment, the stage of disease, and other person-related factors, as well as other things caused by treatment such as loss of skeletal muscle mass, the increase of cytokines as pro-inflammatory markers that we spoke about, disruption of hormonal systems such as the AHA system, and changes in neurotransmitters. Best practice guidelines based on the NCCN just don't happen. Our best practice says that we should be screening at diagnosis, throughout treatment and post-treatment, with providing access to advice and support throughout. However, it's poorly understood by health practitioners. I often talk to health practitioners, and the other day I was talking to someone and he was calling it post-treatment fatigue. The correct term is cancer-related fatigue, and the pathology is not as simple as what we think. The problem with cancer-related fatigue is that the NCCN suggests no less than 16 subjective measures that a person uses to try and measure their fatigue. So it's very hard to actually compare those measures. They capture different domains, and again, they're administered ad hoc, and they're also very subjective. However, recent pooled estimates say that it's present in over half of all cancer survivors. And a cancer survivor is someone who has had a diagnosis of cancer and who has had cancer treatment. We've talked about that it's very complex, it's not well understood, it's subjective reported, and therefore it is underdiagnosed and underreported. Our current management in the literature, and you may get a mix of this depending on the practitioner in the hospital, might be a mix of education. There might be some medication, I've seen that rarely, nutritional and supplements. And in fact, when I was in Japan, it was mostly around nutrition, was the focus of managing the fatigue. Exercise, which It is a modality that is easily measured, therefore easily researched and easily understood. And the benefit of exercise is it can most definitely build that skeletal muscle. So when you are actually stronger, you are automatically less fatigued. It also releases a lot of endorphins, so it's actually a positive thing that people enjoy. And as fatigue can also be a mixture of psychological input, that's where exercise can be very beneficial. However, mind-body interventions, when you're looking at things like Tai Chi and yoga, that are actually trying to connect the mind-body through either movement or other practices such as meditation and mindfulness, have been proved to be just as effective as exercise. So it's a mix, and it will be a mix dependent on the person and what they're receptive to. Using the definition from the NCCN, I've developed my own framework of managing cancer. And what I do is actually provide education and resources to manage each dimension of cancer fatigue, with the aim of trying to build energy and to teach people how to manage their different energy systems. So I've used a bucket framework. I haven't got time to go through all of the framework, but people actually, in my experience, really resonate with it because it's a visual, it's in your mind or visual or through an activity diary. People actually try to measure what energy they've actually got. So you will have a bucket of physical energy, a bucket of cognitive energy, and a bucket of emotional energy. And it's helping people understand when they're starting to participate, whether it's going to the shops or whether it's going to work or they have to go to a birthday party, they start to think through, okay, for example, going to the birthday party, I will take a lot of physical energy because I've got to prepare things, I've got to hop in the car, it's a long trip, I'm going to be on my feet. It probably take a lot of emotional energy because I have to do a lot of socialising, a lot of talking, a lot of remembering people's names, and maybe less of the cognitive energy. And it's about helping people understand if something takes from those buckets, what are some of the tools and resources and things that they can do to either manage it or try to fill those buckets again before they start any other activity. I personally have found it to be a very successful way for people to manage their energy. And I'm working with a fellow at the moment that his wife actually, she's now embraced the framework, and she'll say, well, that's moving that bucket and we need to look at this bucket. So people know, they'll go, okay, well, to fill my physical bucket, going for a walk with my wife fills that for me. Or for my cognitive bucket, actually having some time, just doing some quiet contemplation helps me concentrate again and fills that cognitive bucket. I hope that made sense. This is just a representation of when we're talking about fatigue, there are other risk factors that circle around that fatigue, which we've touched on. It's the type of cancer, it's the treatment schedule. We know some for example, radiotherapy, usually 2 to 3 weeks after the cessation of the block of radiotherapy, people usually report like a very big increase in their fatigue. And you've also got some demographic characteristics, an age of a person, the gender, what type of environment they're living in, whether they're partnered or not. And the pathological factors is the history, the inflammation, and the other issues related to cancer. I would also throw in there some of their other health-related factors, such as obesity, lifestyle habits, history of exercising, history of how they manage stress and their mental health. So this framework certainly helps a practitioner when we're trying to understand and measure, and therefore this helps us inform where we actually might start our intervention. Again, I just put this in just to sort of highlight just the significance. This came from my paper, was that survivors undergoing active treatment can report fatigue as high as 85%. There are more statistics if you're interested, but I think that makes the point. And up to 45% of them report that fatigue is moderate to severe. Survivors can report up to 52% of fatigue up to 3 years post-diagnosis, and possibly we're not measuring it post 3 years. This is where the statistics, you have to take it with a bit of grain of salt, because we're just not good at measuring this condition and understanding it. 1 in 4 survivors of adolescent and young adult cancer can report fatigue up to 30 years post-diagnosis. I've got a friend, so, I'm in my 50s. She was a young primary school age girl. She was diagnosed with leukemia. We still stay in touch, and she still has periods of quite chronic fatigue. And particularly with survivors of cervical, GIT, breast, lymphoma, and mixed cancers, they're reporting high levels of fatigue, probably attributed to they probably had a lot of combination treatment. The impact of cancer-related fatigue is enormous. So I'm just looking at this. I was just trying to think of someone that I could tell you about. Was Miss C. So she worked in a big international company. We got her on a return to work, but her life prior to returning to work was very different. She actually was she was so busy trying to look at alternative therapies, and you find this often, that people, their weeks are just full of acupuncture, or they're full of yoga every day, or they're on some sort of diet. I met a lady this week actually who was wearing an infrared watch and taking some form of supplementation that she got from Mexico. That it was also impacting her energy levels, because she was just so focused on trying to find the magic cure, that it was actually impacting negatively on her function and quality of life. She had ongoing reconstructive surgery for breast cancer, huge financial impact. Again, very big impact on the family. Clinical diagnosis of anxiety and depression under the care of a psychiatrist. And in the end, she could really only function of a morning. So my work was with her trying to actually match that sort of high demand energy activity around certain parts of the day, and looking at other parts of the day where it could be more restorative and filling up those buckets. So fatigue survivors actually report that fatigue has a greater impact on function and quality of life, more so than pain and depression. Not surprisingly, they say they have a reduced employment participation, and they're actually working less hours. So if you think bigger picture, there's also quite a big financial loss to the economy as well as to the person. And as people have more chronic conditions that they're managing, and more reliance on the health system, there's actually more healthcare burden. Oops, sorry, I don't know how to go back to the last one. Oops, I don't know how to go back. Sorry, I'll just read it. So, in summary, there were 19 million people near cancer diagnosis and 10 million deaths in 2020. By 2040, we're expecting that number of near cancer diagnoses to reach 28 million. More people are surviving because our treatments are becoming more successful. So therefore, cancer as a disease is often now considered a chronic disease, and we should be managing it in that way. Symptom management is relatively misunderstood and underutilised, and fatigue can be prevalent for many years. It impacts all domains of a person's physical, financial, and social functioning. Thank you very much. I'm really happy. I know I've spoken for a long time. For questions.
Yeah, thank you so much, Vicki. That was very informative. So yeah, if anyone has any questions, please unmute yourself and just come forward. And I'm not sure if you are able to see the chat there, Vicki. Can you see the chat?
can, I
Yeah,
can,
so Patty made a comment that she agreed with your screening comments. So
oh,
yeah.
yes, it was, actually, we actually had a whole couple of sessions at uni on COVID, and we're really looking at the impact. One of the subjects in my degree was actually cancer screening, and trying to actually look at the barriers that COVID actually made. And I think Patty's made another excellent point that people were actually, if they're already sick or they're feeling sick, they were really fearful of actually accessing the doctors and accessing the hospitals for fear of actually getting COVID. So it is something that, you know, internationally we're very aware of. I haven't got any other sort of statistics because I haven't focused on that for a while. But yeah, thank you for supporting that, Patty. I'm really, as I said, I know this can be sometimes challenging to listen to. If people would like to talk to me offline, I'm really happy to do that. It can be upsetting. Cancer is something that touches a lot of us, most of us. And I think the support around the supportive care is something that I'm very passionate about, and that we can actually help people manage this better. We can actually do a better job.
Yep. Yeah, so does anyone have any question? Please unmute yourself. Um,
Thank you for everybody's time.
yeah, so if no one does, yes, thank you so much, Vicky, for doing this with us. And thank you everyone for joining. So I'm gonna stop the recording now.